Thank you so much, and thank you guys for all sitting here. It's like really, truly an honor. And I was looking at the lineup of speakers we had this morning, just like overwhelmed with the talent. I mean, just the knowledge, and I can't ever imagine having a group of speakers like that in the pancreas, one after another after another. It's just incredible. So thank you guys all for coming and for inviting me back. So I'm going to talk a little bit about management of acute pancreatitis, and I'm going to try not to retread too much. Mine's going to be a combination of knowledge and also kind of hopefully a little bit of visionary stuff as far as what you as fellows can do in acute pancreatitis, because I think, oh boy, about 14 years ago, I was sitting right where you were, scared. I'm an introvert. I don't like to talk to people. And I was just sitting there looking around like, please don't call on me. Just get me back to Little New Hampshire. So things kind of progress and go as we go. And so hopefully I can inspire you a little bit about what moving forward. So for those of you who don't know, there we go. So this is about to happen. So I just was back there. So I think at noon we're going to start to be involved in, I think the second biggest air show in the country is going to be flying right outside our window. So just in case you don't know, I think the Blue Angels are coming at 4. So I don't know, as organizers, we know about that. Yeah, but just so there's going to be things falling from the sky and that's all going to start, I think, in an hour and a half. So anyway, just so you all know. What board meeting? Okay, here we go. Anyway, all right, so just so you guys know. So objectives is, so Dr. Lewis has talked about wellness, physician wellness, so this is, I think, pretty cool if you can look out the window. Okay, so I'm going to talk a little bit about fluid resuscitation, a little bit differently than George covered, I think, but we're going to talk a little bit about, antibiotic therapy and you guys know where, and nutritional support, all of which is going to be covered in some pure mutations elsewhere. So, come on. There we go. So for those of you guys who don't know, and I think most of the senior folks in the audience do know, acute pancreatitis is the most common reason patients with a gastrointestinal illness get admitted to the hospital in the United States. Okay? So one of the nice things is that we have a lot of opportunities to try to help our patients, but one of the downside is we don't have a lot we can do for them from a pharmacological intervention perspective. So keep that in mind. We're dealing with an illness that is the most common reason a patient's going to be on your GI service when you're in the hospital. So very, very common, lots of opportunities in which to intervene. And I'm just going to show you guys a case here really quick, assuming... Okay, so here's just a classic case presentation for pancreatitis. I'm not going to belabor this too much. Epigastric abdominal pain, 52-year-old, chronic alcoholism, back pain. He's got febrile. Here's his labs here. And you kind of look at this, and if you're like me or, you're a second, third-year fellow, you're like, ho-hum, whatever. Why are they calling me for a GI consult? But what I want you guys to do is think about this in a way of there is so much here in this presentation that we do not know about. Okay, so as you start to think about these patients, you start to think about what you can do from a research perspective or how you can improve the lives of your patients. Start thinking about all the things that you do when you look at this that you just blow over. Okay, you don't even think about it. You take for granted, and if you start to think about that as a way to kind of frame your research questions, it'll really, really inform you. So, for example, if you look at this, 52-year-old male. Okay. Do we know a lot about how different pediatric patients are from adult patients, really, when they present with acute pancreatitis? And we have this amazing group led by Myson that's looking at this. They are different, apparently, but are they? I don't know, but all right. But anyway, my point is that you look at this and you say, is there a difference? Is the natural history different from adult and pediatrics? This patient has chronic alcoholism. I know DR's just done a lot of work, and it's how much, I say chronic alcoholism, but what does that mean? How much is that? Can we quantify that? That's pretty simple to look at. Lipase down there, 1200. Why is that not in any sort of predictive scoring system that we have? What's going on with that from a pathophysiological mechanism? You start looking at creatinine. We talk about creatinine as a marker of organ failure, right? That's one of our markers. But why is that? Why are we using that? Who decided that? Okay. And then you start looking at optimal markers of hemoconcentration. We looked at this. Peter Banks was, the one who really set this up. But you start saying, well, is this the better predictor? These are all little things that you can look at, and then you start looking at the liver tests, and we say an ALT greater than 150 is predictive of biliary pancreatitis, but that's from one study, and do we need to really study that again? So I just kind of threw this up, as we talk about these cases, but when you're on the wards and you're thinking about this stuff, like there's so many unanswered questions we have in acute pancreatitis, and use your clinical experience to help inform those research questions that you want to make, and so just this one simple slide, there's so many things that we don't know, and these don't involve randomized controlled trials. You can sort this out other ways. So where am I pointing, by the way? Does anybody know?
Pointing to the front.
Pointing to the front. Okay, sorry. So again, this is our patient who comes in, and we're going to get some more talks today about imaging. But you take a look at this CT scan, and at Dartmouth, they just installed CT scanners at the ER entrance. So as you walk in, you get a CT scan. So even though we're not supposed to get like CT scans, in acute pancreatitis, you look at this and you say, oh my God, this is a horrific CT scan, right? This is a horrific CT scan for someone who's presenting, because basically you've got complete hypoperfusion of the pancreas, right? So you know right away that this patient's going to probably have a very rough course. And there's so many questions you can ask just about this, about, why is the pancreas hyperperfusing, the fat necrosis, peripancreatic fat necrosis. There's so many different things you can ask yourself. And so these are the kind of things that you want to think about as you're moving forward in developing your research questions. I'm pointing directly towards these guys. There we go. Okay, so you have this patient, it's the sixth patient that you've seen that night, and you're sitting there, you're saying, all right, well, what are the questions I have to consider? This is a patient who's obviously got SIRS, who's sick, who's got a horrible looking CT scan with a hyperperfused pancreas, who's probably going to develop, if not mild, probably severe pancreatitis with necrosis. And you're asking yourself these questions, like what fluid order should I write? Should I put this patient on antibiotics? What should I do for feeding? These are all the kind of the things that we think about. Unfortunately, I don't have a thing that says which of the pharmacological therapies are we going to use to treat this patient with acute pancreatitis, and that's obviously what we need moving forward. So thinking about fluid resuscitation, George covered this a bit, but basically this is an alteration in the pancreatic microcirculation. You get increased vascular permeability, develop of free radicals, all sorts of inflammatory cytokines, which lead to second generation of acinar cell injury, and that's where you get the release of your pro-inflammatory cytokines, also your anti-inflammatory cytokines. And just think about how much there is here in these inflammatory cytokines. We now have drugs, and Dr. Prakishka talked about this, that modify inflammatory markers. So like, why aren't we giving Remicade for acute pancreatitis, right? Kind of a silly question, right? But in a way, you start thinking along those lines, like, why are we not doing that? Why are we not taking these patients? We have these drugs. Why aren't we doing cytokine profiles in these patients and targeting those cytokine profiles? I'm not doing it, but certainly you guys can do it. These are all things that we can do for acute pancreatitis, right? And then what happens once you get those pro-inflammatory mediators, you get secondary vasoconstriction, which leads to a whole post-secondary aspect of pro-inflammatory mediators, okay? So my point in showing you guys this is not to kind of dive into the basic science, of which I'm not qualified to do, but to say, hey, there's so many opportunities. We're now getting all these amazing therapies for other diseases. The IBD docs haven't come up with one thing original in their lives, right? They steal it all from rheumatoid arthritis, right? But look what they've done. Why can't we do that? From in our group. So again, something to think about in regards to pancreatitis. So when I was, is he still here? Dr. Vega is not here. So when I was a fellow, advanced fellow, we had these questions like, what fluid orders do we write? And really, there was nothing really that had been written on fluid resuscitation in acute pancreatitis from a kind of rigorous scientific view. And I was a fellow at Mayo, and Dr. Vega was my mentor there. And he said, well, why don't you write a review? Take a look, write a review article on this, and let's see what we can come up with. So, that's what we did. We looked at this, and we looked back at the literature and found that everything that we had was based on expert opinion. So this is what we came up with. This is an article from 2008, and these were some of the great, you see Dr. Whitcomb with his New England Journal of Medicine review, and Dr., look at these names, Vega, Banks, Tenner, Forsmark, Chris is in the audience, amazing folks, but it was kind of all over the map as far as fluid resuscitation. This was all based on expert opinion. It was all around the same ballpark, but there was no rigorous studies that had really been done to look at this. So, we kind of looked at this a little bit. Again, I was kind of a sheepish little New Hampshire guy, and I said, well, let's see if we can do some retrospective and then try to come up with potentially some perspective data, in regards to this. And there we go. So at that time, there were really no prospective studies. There was one from Sweden, but it was really not well done. And so basically over the course of the next 3 years, 2 studies came out, one of which we were involved with, which I'm talking about a little bit more, but one of which George mentioned, this study from China, which was really an amazing study in patients, about 250 patients with predicted severe pancreatitis. They took these patients and they just randomized them to kind of some gentle hydration, and then they really, really hit them with hydration. They took these patients within 24 to 48 hours, and they dropped her hematocrit to 35%. Okay, so you can imagine the amount of fluid it took in this Chinese group. So these were patients with predicted severe pancreatitis, and what they found in the patients who had rapid hemodilution, George went over this, is that they did so much worse. These patients did terribly compared to the patients who had slow hemodilution. Now remember, hematocrit less than 35% within 24 to 48 hours is a dramatic amount of fluids. But these patients did really worse. In fact, look at their in-hospital survival rate, right? It was 20% less relatively than those who had a slow hemodilution. So you had this study come out of China, severe acute pancreatitis, saying that, this aggressive fluid resuscitation, really aggressive, is probably not a great idea, okay? And it was praised for a large number of patients, but it was kind of an unusual treatment approach. No one's cranking people with 25 liters of fluids. That's right, Christina, my fellow. I always hammer on the fluids. We don't do 25 liters of fluids in the first 24 hours. All right? So we had this idea to look at fluid resuscitation in a little bit different way. And you guys all recognize this guy. He looks much better now than he did back then, Dr. Singh. All right, good-looking guy. And Vic was a fellow at Brigham. And you've heard Beach and Wu, who unfortunately is not here. He was a fellow at Brigham. And I was 2 hours away up at Dartmouth. And through the NPF symposium, Peter Banks, who unfortunately isn't here, who many of us know, got us all together. We had met at the NPF symposium. And remember, we met for lunch just outside of Fenway Park. I don't think we were too poor to get tickets to the game. But we met outside the park, and we started talking about a fluid resuscitation trial, okay? And this is directly from the NPF. This comes directly from this meeting in 2006 where we met. And really, Beechin took the lead on this and developed this trial, which is right here, which was published in CGH in 2011, which George alluded to, in which he looked at 2 groups of patients. There were patients who had goal-directed therapy, so very, very well-prescribed rates of fluid resuscitation, and they were randomized to either receive that dose with LR or that dose with normal saline. And then there was another group that received standard of care, which whatever that was, again, the groups were randomized to LR and normal saline. So there was basically 4 groups in this arm. And this was a really simple study. This is something that any of you in this room can do, okay? And what he did is he ran this out of Boston, out of Brigham and Women's Hospital, and there was Faulkner Hospital as well, which is a satellite hospital, Brigham. And then we were up at Dartmouth in the woods, and I had a fellow help me, and I was a young attending, and we ran this trial, okay? And we just looked at just like this. So patients came in with acute pancreatitis. This is the access down here, says the time they were entered into the trial, 8 hours, 16 hours, 24 hours. And they got a bolus of fluid, LR or normal saline. This was the patients who were in the goal-directed. And they had a checkpoint. They got their BUN. That's what we looked at. Did their BUN go up or did their BUN go down? And if it went up, they got more fluid. If it went down, we held steady. And we did this 2 more times over 24 hours. You can't design a more simple study than this, okay? But this was really the first time patients were randomized between saline and LR. And we have Fred to thank for that because he made that recommendation in the trials because he was seeing things in the lab. And again, we did this. And this is where I think we had the first suggestion, and this was only in about 44 patients, I believe, but the first suggestion in looking at patients who had LR and normal saline, all comers, that if you looked at the SIRS response, the LR patients had a greater drop, so you can see admission is in black, 24 hours later is in white, and you can see with LR the amount of SIRS really dropped, okay? This is not an earth-shattering study. This is not, New England Journal of Medicine material, but this is a randomized treatment trial in acute pancreatitis. Wendy, I got 5 minutes, okay? And we saw the same thing there in LR. So this is just an example of what can happen with fluid resuscitation, and subsequently, as George told you, there's many trials, and this is one of them that's come on, but essentially this is now something that the NIH is very much interested in, and it all stemmed right here from this meeting. So my point is that, again, you guys can do it, okay? So we make some recommendations as far as LR, and I think pretty universally now, everyone's using LR for the treatment of acute pancreatitis, okay? So antibiotic therapy. Again, there's two questions when patients come in for antibiotics. Do they prevent a bad clinical outcome? So do you give patients antibiotics when they walk in? And if they have infected necrosis, do you go ahead and can you treat them with medical therapy only? And there's been a lot of study on this, but I just want to show you, look at these studies. There's 3 good randomized trials looking at patients who are given admission antibiotics to prevent severe acute pancreatitis. That's it, 3, okay? And they're all a little bit on the left of the a summary statistic, but 2 of them are not statistically significant. But basically what we say is imipenem at least does not prevent development of infected necrosis. My point in showing you this is there's lots of room for more studies. If you look at mortality, again, the mortality shows that this does not improve infected necrosis. But look, there aren't many studies at all. There's so much room to do a nice big collaborative study in this regard. This is a study, a retrospective study. I was once told that retrospective studies don't tell you anything, that you have to do a randomized controlled trial. I think this is an amazing retrospective study from Pramad's Gar group in India, where they looked at patients who had infected pancreatic necrosis. They had interstitial versus infected versus sterile necrosis, and this just shows over time whether or not these patients were treated medically or surgically. And what you can see over time is that the patients in these groups, more and more of them were treated medically. So it used to be the dogma that infected necrosis required surgery. Not anymore. You can treat these patients medically, okay? And there's just more data here which looks at a meta-analysis looking at this. Can we use not surgical treatment? And you look at this, all this went into this meta-analysis. There was only one randomized controlled trial. Okay, so there's lots of opportunity to do this stuff, and it said that by 64% of patients were treated with medical therapy only. So you can use imipenem to treat infected necrosis. You can get away with it without doing surgery. Nutritional support, I'm not going to belabor this. This is, again, another meta-analysis that just shows that we got to use the gut. Okay, I got 2 minutes. Enteral nutrition improves mortality. This is a randomized trial that was absolutely fantastic from the New England Journal, Dutch Acute Pancreatitis Study Group, which showed that if you randomize people to oral feeding versus nasoenteric feeding within the first 72 hours, patients do just as well with oral feeding than they do with nasoenteric feeding. So you can feed patients when they come, and you don't have to put an NG tube in or an NJ tube in, okay? So basically what we do for nutritional support is we use the gut early, we use it often. You don't necessarily need to use those feeding tubes. And this is a much better way to do things than obviously TPN. So there's lots of controversies, when it comes to acute pancreatitis, and I just listed some of these here. But the biggest thing is this point here at the bottom. Can we use targeted anti-inflammatory therapies treating acute pancreatitis? And I can tell you that drug companies are very much interested in this. There's phase 2 trials going on in several different areas, but this is really where the money's going to be. So last slide here is, again, this AGA acute pancreatitis technical review and guideline. Fortunately, I was able to be a part of this, which is really cool. But what's really even cooler, and the best part about this, is that my mentor, Dr. Vega, is on that, as is Chris Forsmark there too. But this really meant a lot to me to come from a little guy in Vermont. Not that I'm anything special, but to be on there with my mentor was really, really great. So thank you guys so much.
Thank you, Tim. We do have room for a couple of questions. So I have a comment for the pediatric subgroup, which we are probably kind of a majority. Can you raise your hand if you're pediatrics? Higher? Okay, so maybe a quarter of the room.
They're just little adults.
Yes. So They're not mini adults. They don't drink alcohol. At least I hope your 10-year-old is not getting into the bourbon
We'll see.
cabinet.
We'll see.
So the LR versus normal saline question is being answered right now. When you look at clinicaltrials.gov, the study is multi-center, and we're hosting it at Cincinnati Children's. And stay tuned. Hopefully in a year from now, we'll get out to our target enrollment. So we still, in our guidelines, and will be covered later by Veronique and Dr. Mark Lowe, we do not recommend one fluid over the other. But I do believe this is also for adults. Some centers say we strictly switch to LR. I heard one time from a person, well, if you don't use LR, it's malpractice. I think these are strong statements. Until we have the bigger studies of thousands of patients and know at goal-directed therapy and how would you predict severity and how you tailor that therapy, we are still saying, as of the AGA new guidelines, that maybe LR is beneficial. You would agree?
I would.
Okay, sounds good.
I know not
Veronique.
to disagree.
More a comment, and also to the fellows, I think it's fantastic that you're highlighting that there's so much left to be done. And one of the things that always struck me in pediatrics is, you look at some of these studies and, you're looking at hematocrit and whatnot. And I think, I always like, how can you treat everybody the same? And I think that's what pediatrics highlights, right? Depending on the age and the gender, pre-puberty, post-puberty, normal hematocrit changes, all these factors change. And I think that might be part of the issue sometimes with some of the adult studies, that you're putting everybody together.
Sure.
And maybe there needs to be more separation of the type of patients. And maybe pediatrics can help that way to try to tease out other factors.
Yeah. I totally agree. Etiology-directed management probably one day is how we're going to go.
Thank you. Thank you. Tim, that was a very, very nice, fair overview. One comment and then one question. So some things that weren't in our lactate paper that may be important to consider, because all that studies were done in mice. We did have parallel studies in humans showing that it also suppressed human macrophage activation and inflammasome activation. One question was, what's the durability? Okay, if you give a bolus of lactate, how long does that last in suppressing that? And we found in mice, it was about 6 hours. We did that study and isolated human cells, and it lasted around the same period of time. But one possibility is that you can basically just give it as a bolus. Another question we asked is whether you could give it PO and what happens to lactate absorption. And you do get reasonable amount of lactate absorption, PO. We don't know what happens in pancreatitis, though, and whether it be an effective therapy that way. One caution is, and I think when you came down we chatted about this, is we did very short-term studies. We really didn't parallel the human, treatment condition. And when the amount of lactate you need in the serum to activate that receptor, the critical receptor, is about 3 times physiologic levels. You don't need a lot of lactate to activate it. And what we found, never published, was when you get much higher levels, you activate some other pathways that might be deleterious. So it's something to think about, and maybe in the studies, it may be worthwhile even monitoring those to see what their effect is. So those comments and things that we never stated that might be useful to think about. The study from Baxbaum, I think, raised an important issue, and that was they stratified patients and put those with cardiac disease and renal dysfunction in another category, and were able to put in 7 liters, I think, on average without harm. When you're thinking about giving volume repletion, do you look at that or think about that in considering limits to what you're going to give individuals?
Yeah, absolutely. I mean, I think it's really important to, not do this in isolation, and obviously when your ICU nurse is looking at you and you're saying, yeah, give a liter more, and they're in fluid failure, that's something that, but I think from my perspective, I'd rather have them in the ICU intubated, and volume overloaded than dry on the floor.
Okay, well, thank you so much. We'll move to the last speaker before the breakout.